What's up, everybody, and welcome back to the It Matters podcast. First and foremost, if you want to show your support, don't forget to subscribe to the Facebook page to stay updated with all the content coming up. Now I'd like to tell you something about my friends at Sneaks. Sneaks is basically all about sneakers. These guys are so passionate about the quality of their products and absolutely in love with sneakers. Each pair of them has its own story and personality. However, they believe that sneakers are often the ones who actually find us and not the other way around. And this is how their story started. Do you want to keep going? Choose sneaks and make the step. So today's guest is a former New York psychiatrist specialized in geriatric psychiatry and Alzheimer's disease, currently a researcher in the field of neurodegenerative diseases that focuses on the impact that these pathological processes have on patients' lives. The first interaction with medicine dates back to when he was still in high school. Pushed by his parents to start making ends meet, he signed up as an orderly, pushing patients in wheelchairs from one clinic to another. He kept his job also during college when he was promoted to an operating room orderly, eventually being offered the opportunity to become a surgical technician. In the third year of medical school, he dropped out, moved from Paris back to the US, and got a degree in clinical psychiatry. After that, he applied to Vanderbilt University in Nashville, Tennessee in order to continue his studies, having the opportunity to work with people that set up the basis of neuropsychopharmacology. He was trained in setting up clinical psychopharmacological studies and the importance of clinical rating scales as well as how to develop them. He then moved to New York University Medical Center. Over there, physicians were also involved in setting up the American College of Psychopharmacology. Having a medical background on his resume, he was hired on the spot and pursued a postdoctoral fellowship in geriatric psychiatry. The Geriatric Depression program, which was running that time and got stuck around differentiating geriatric depression from early memory disorders, acted as the milestone for his future geriatric and Alzheimer's disease research. Without further introduction, please help me in welcoming the man that used his passion for talking to people and determination to figure out how Alzheimer's disease affects the quality of patients' lives to propel him amongst the few researchers that put together FAST, BEHAVE-AD, and GDS clinical rating scales, Professor Stephen Sclan. Professor, thank you for coming here and welcome to the It Matters podcast. I'm really glad to have you here.
I'm glad to be here. Thank you.
I saw and I attended your lectures 2 days ago, and it was quite fascinating and amazing, and I really love that you had this different approach that lacks nowadays in our medical field, in our society. And I'll start by asking you how did you end up doing medicine and in the medical field?
A long story, but I'll try and do the short piece of it. I was principally in a position where for many years as a younger person, I had to work to support myself through school. I will say, as per our earlier conversation, I did receive some financial help from my parents, but my father made it clear that he always wanted me to earn a significant amount of my keep as a younger person. Even though he could afford to help 100%, he didn't do that because he had some pretty strong beliefs about bringing up kids. And as a function of that, I found work part-time in hospitals, starting off as actually in English what would be called an orderly position. You know, the people who, I don't know what it's called in Romanian, but the people who would push the patients in the wheelchairs from one clinic to another.
Okay.
You know, from radiology to chemistry or from serology to radiology.
And basically that was the lowest position
Absolutely,
you can have in a hospital.
Absolutely.
Okay.
And and I was paid on an hourly basis. And actually, both in my last 2 years of high school and my first year of college, I was working part-time doing that position. And so very early in my life, I became accustomed, therefore, to hospitals and to medical settings. And frankly, I have to admit that I enjoyed working with people. I always enjoyed talking to people. I still do. And it was always fun to talk to the people, to the patients who I was, pushing around through the hallways. So I really felt quite comfortable in a hospital setting. And over a period of time, particularly once I went to college, as you know, our system is a little bit different than the European system.
I know.
But as I went through the college experience, I actually moved from being an orderly, pushing patients around. I was promoted and I became an orderly in the OR. Which was a slight advancement. Then I was in charge of bringing the patients from their rooms into the OR prior to the surgery.
Right.
And leaving them in the hallway, lined up along the hallways. And I did that part-time for a while. And the real change happened one summer when I was actually offered training as, in English, what we call a surgical technician.
Okay.
I became a surgical technician. I was in school in Washington, D.C., and I was licensed in Washington, D.C., in Maryland, and in Virginia. A little geography there. And I actually, at that point, it was an amazing period because I was, for a college student, earning a really good salary.
All right.
For not very much work.
Okay.
And so that's how I got into the whole field of medicine to begin with. I think I was, as I mentioned, I really enjoyed talking to people. And I was very much interested in psychology and psychiatry at that point. Not so much, and of course things have changed a little bit. This was at that point, my interest was in dynamic psychiatry and talking to people. And so I thought that I would go into psychiatry. And I really did. I think people started giving me feedback at that point about feeling that I had sort of a talent for asking people questions and for talking about things. So, as I mentioned, I did in fact go to medical school, and I went through 3 years of medical school. I was actually in Paris for 1 year and in Brussels for 2.
Okay.
And that's why I can speak fluent French.
Nice.
Yeah, well, the French are not terribly open to speaking anything other than French.
I know that.
So, but it was a great experience. However, I became frustrated, frankly, because I was, at that point, became much more interested in the psychology and the personal interaction. Also, the times were different. This was the early 1970s, late 60s. And I dropped out of medical school. And I actually I went back to the States, and I worked for a while in the States. And then I continued my professional education and got a degree eventually in clinical psychology.
Okay.
I had the background, however, in medicine.
Mm-hmm.
This was significant in terms of a change of my career. Because of the background that I had in medicine, when I applied to programs in clinical psychology, I was heavily recruited by a couple of different well-known places where in the departments of psychiatry, and there's often an overlap between the PhD clinical programs and the departments of psychiatry, particularly when it comes to research. Mm-hmm. So I was particularly heavily recruited by certain departments of certain universities where there was a strong overlap in psychopharmacology and clinical psychology. And there were, I won't name them all, but I finally got I took what I thought was not only the best offer, but a pleasant place to live. I went to Vanderbilt University in Nashville, Tennessee, which had excuse me, it still has a very strong program in clinical psychopharmacology research. There were some people, the reason I chose it was because there were some people who were in the Department of Psychiatry who had founded the ACNP, the American College of Neuropsychopharmacology, and who had also been instrumental in beginning the Clinical Drug Evaluation Unit in Washington, D.C. through the National Institutes of Mental Health.
Okay.
This has to do now with the history of psychopharmacology. NCDU, the New Clinical Drug Evaluation Unit. There were 2 or 3 people who were in the Department of Psychiatry who had been clinical research personnel in NCDU in NIMH in Washington, D.C., and then were recruited themselves at Vanderbilt. And then they went ahead and they recruited me. And I have to say, at that point, by recruit, I had a very good deal financially. And I finished my clinical psychology courses, and I did a great deal of work at a very specialized clinical psychopharm research institute run by Vanderbilt School of Medicine called Tennessee Neuropsychiatric Institute, abbreviated TNI, where these people all were. And I was trained through the 5 or 6, well, more than 5 or 6, I was there for close to 10 years. I was trained through the last few years of my program, and that's where I did my research, my dissertation research at TNI. I was trained in setting up clinical psychopharmacologic research studies, how to do them, the importance of clinical rating scales. That was one of the things that we talked about in the presentation. How to set up clinical rating scales, how to develop new clinical rating scales, how to deal with certain patients. Now, this was all, these patients at that point were schizophrenic and very severely depressed, how to work with inpatients and do innovative psychopharm research. So that was really how I got into the field.
All right.
That was it. Now, there's more. Should I continue with this?
Of course.
Okay. So, at that point in time, this was a very small group of specialized people, not just at Vanderbilt, but around the country. And at that point, it's interesting to reflect back, Andre. At that point, I still actually had thoughts of becoming a psychoanalyst. Okay. So I was doing all this work in psychopharmacology, and I have, as I look back at it now, it was one of the greatest periods of time in my life, because obviously I was moving around with all these people. You may or may not have heard of their names: Thomas Band, Bill Guy, Friedel Sulzer. These were people who were fundamental in starting the American College of Neuropsychopharmacology. So I thought I was on top. I was soaking all of this in, and I was also having a great time because I was on the wards with the patients who, I have to say, I loved. I have always loved psychiatric patients. Okay, and the more acutely psychotically disturbed, the better off I am.
That's quite interesting.
Okay?
I have to say.
Yeah, I mean, it's and my clinical work reflects that, because clinically throughout my career, I have worked with the most severely, extremely acting out patients that most people have had. You know, all those patients who everybody says on a clinical basis they don't want to work with, I always took.
Okay.
It was always a challenge to me. And I look back and I think about every single one of those patients now. I don't think I've ever forgotten any of them. Seriously. I can see their faces in my head. I can generally remember their names, and I can even remember most of the stories.
That's quite amazing.
It was absolutely a great experience. So I worked with the people at TNI. I thought I wanted to be a psychoanalyst. back in New York. And so after I finished the degree, I was offered a position at Vanderbilt to run one of the inpatient units, actually, which was a great honor because I had just finished my training. But I wanted to study psychoanalysis and be another Sigmund Freud.
Okay.
Okay, what can I say? So we went back to New York, and I did, in fact, for 2 years, work at a Psychoanalytic Training Institute in New York. I studied I was in the Psychoanalytic Training program, and I was working during the day seeing patients who were coming in for therapy. So I have that whole thing in my background, which is really good. I have that whole background in terms of understanding what I refer to as the more psychodynamic aspects of what goes on with psychiatric patients, and the extended the family and the extended family. But I didn't, at that point in time, I guess I didn't realize the impact that the experience at Vanderbilt had really had on me. I knew that I had worked with some very well-known, well-trained, really expert people in psychopharmacology. Obviously, I knew their credentials. I had personal interaction with them. They had personal interaction with me. They supervised and were on my doctoral research committee. But when you're younger, you don't necessarily appreciate the impact that people have on you in that moment. So as I was spending my time in the Analytic Institute, I found that there were a lot of things that I was being asked to do in terms of professional interaction with patients. And there was also a lot of thinking that was going on that I was not any longer completely comfortable with. There were some episodes where I really did feel that there were some clinical issues that were being missed, clinical, physiologic, organic issues that were being missed and interpreted in an incorrect way. And I was right on one or two of them, which were extremely meaningful for me. And I became a bit impatient, and I started looking for other work in New York.
Okay.
And at that point, I was living with my wife, we were living on, I don't know how familiar you are, but we were living on 30th Street and 2nd Avenue, which is literally a stone's throw away from NYU Medical Center, New York University Medical Center. And I have to date myself. I hate to do this, but these were the days just as desktop computers were coming into force.
Okay.
Right? The computer systems at that point were the big things that were in the basements of buildings for the most part. Bill Gates had just begun to mass produce the desktops.
Right.
And so the reason I'm mentioning that is because the New York Times used to have a section for professionals, medical professionals looking for work. It was not on the computer, it was in the newspaper every Sunday. Mm-hmm. So I was looking through the ads in a newspaper, in the Sunday New York Times, and there was an ad for NYU Medical Center for postdoc fellowships in psychiatry. And some of them were in psychopharmacology, and others were in geriatric psychiatry, psychopharmacology. And it was just 2 blocks away. It wasn't even 2 blocks away.
Right.
You could see it out of my front window. So I sent my CV in, and when they found out, when it was read, and they found out, of course, that I had gone to Vanderbilt and TNI, the group at NYU also had been involved in setting up the American College of Neuropsychopharmacology. Mm-hmm. So bingo. And I went in for the interview. My interview was not in the medical center, but in a coffee shop across the street from Bellevue Hospital for lunch, which was great. And they paid for it. And that was an NIMH, National Institute of Mental Health, postdoc fellowship in geriatric psychiatry. I was the first clinical psychologist I was brought in, and I had that position. I was the first clinical psychologist at that point to be appointed within psychiatry as a clinical person. I had prescribing privileges because of my background in medicine.
Okay.
I had prescribing privileges within the hospital, and it was a 2-year postdoc fellowship, clinical and clinical research. The first year we were rotated through a variety of clinics, just as any resident was. We were rotated through a variety of clinics that specialized at various hospitals that New York University ran in New York City for geriatrics and geriatric medicine, geriatric psychiatry. And I also had to do work at Bellevue Hospital. And a couple of days a week, we were exposed to the clinical psychopharmacology research that was being done at a another very well-known psychopharm research lab called Milhauser Labs, which was the psychopharm research piece of the Department of Psychiatry at that time of New York University Medical Center. And there were some really amazing people there. And many of the people who were there were very close friends with the people at Vanderbilt. So, as it turned out, of course, I was exposed to that, and I continued in Milhauser Labs. There was a geriatric depression program going on at that time, run by a guy by the name of, who was also well known, Anastas Georgotis. He was Greek, and he had been sort of one of the founders of geriatric psychopharmacology, and they were having difficulty differentiating geriatric depression from early memory disorders in geriatric patients.
So this is how you're interested in...
That's it. So that was where the geriatric and then the Alzheimer's piece came from.
Oh, okay.
So there's a long story. I hope it wasn't too long or too boring.
It's not.
But that's how I started.
All right. That was my next question. How your interest in the Alzheimer's disease field and the dementia field started. And I think that you mentioned in the beginning of our discussion that you really like talking to people, spending time with them, and I now hearing you and all your experiences, I really think that you really emphasize the thing you mentioned people everywhere you were, that you like the people there, people. Okay, so I know that you helped and worked in developing the scales for the Alzheimer's disease, right? The FAST, the BEHAVE, the GDS, right? And you said, I heard it at the lecture, that you like the aspect of the functional aspect that these mental disorders are impacting on people. And why do you think these scales are so much important added to the classical testing of the Alzheimer's disease?
I'm glad you asked that, and it's a good question. It's important. As I mentioned in the presentation, at the time I got involved with the one or two people who were starting this larger Alzheimer's program, and then we all developed along with it. There was a certain amount that was known with regard to some of the cognitive progression of Alzheimer's. But there was virtually, as I said, there was really nothing that was really known about what happened inside someone's house or inside someone's apartment. And again, keep in mind, it's interesting. I'm really enjoying this. My early interests in medicine came not only from pushing patients through hallways, but as I mentioned, even at Vanderbilt, initially I was working with very severely depressed psychotic patients or schizophrenic patients. And I was really personally really mesmerized by how the distorted thought process impacted their daily lives and how they ended up in a psychiatric institution. So what was going on at NYU was that, or I should say what was going on with the field of Alzheimer's, was that there was so much emphasis on the cognitive testing. And at that point, as I mentioned, the computers were just sort of coming out, and people were starting computerized cognitive assessment, the batteries. They were actually translating a lot of the old psychological tests in such a way that they could be reproduced on the computer, and then people could sit in front of the computer and do it. But there was no interaction, with the, generally at that point in time, with the spouse, who would be sitting in a corner. Generally, it was generally a wife, but sometimes it was an older man. They would be sitting in a corner, and you'd be looking at them, and they looked like the depressed patients that we would see in the hospital. They were okay cognitively, but you could see nobody's talking to them. Nobody's asking them, well, what's going on in the home? What's going on with you? And I started to think, to myself that there was something that we were missing here. And that was how we began, that was the interest in understanding, or trying to understand, what was actually happening when the patient was not sitting in front of the computer.
Right.
I mean, here's this older guy who's, of course now I'm sitting here, I'm younger than I'm maybe a little bit younger than they are, maybe a little bit older, but here's this 80-year-old guy, keep in mind this is in Manhattan, who had to come in with his wife on a train and a subway. How did they get there? I mean, it was hard enough for me, and I was significantly younger. It was hard enough for me to get around in New York City.
Right.
As I mentioned, we didn't have a car. I didn't want a car. Yeah. It's a pain in the neck, especially when it's snowing out.
Right.
I mean, so how did you get your wife in when she's demented? How did you do that? So I was really fascinated by what the impact of the lowered cognition was on what was going on in people's everyday lives.
Basically, their quality of life.
Yeah.
Right.
Yeah. And that was my interest. And of course, we all started. It wasn't just me. I mean, I could not point to any one person. We had rounds every week where we'd go through the patients and we would discuss all this. And over time, we started to realize that that the impact of this disorder on what was happening in the homes was extremely important, and we were missing that. Everybody was missing that. There were a couple of clinical rating scales that were being used to evaluate activities of daily living at that point, but I don't know how familiar you are with it, but at that point, these were scales that were used by rehabilitation people in the U.S. for, people who had either a broken leg or back surgery. They were younger people. Okay. And it had little to do with what was going on with Alzheimer's disease. So that was, if that answers the question, that's how we got into it.
Can you detail a bit the scales that you helped in developing, just in a few words, so people that could understand their importance and how they relate basically to the problems that these diseases pose?
You mean the names of the scales and
the
what
names,
they do?
And what they
sure.
do,
Yeah, sure. The Global Deterioration Scale, the GDS, was the first scale. That was actually underway just as I got there and was doing the fellowship. So I was involved in that, but that was not where I started. As part of my postdoc fellowship program, I helped a little bit, but that wasn't where I started. Barry Reesberg started that. That's the Global Deterioration Scale. But we all became involved in the first one that we really began to sort of capitalize on, was the Functional Assessment Staging Scale, or FAST, which is what I described is the scale for looking at the changes in instrumental and basic activities of daily living or functional behavior. And over time, we found out some qualities that were extremely important about the pattern of deterioration. Through the use and development of this scale, we learned that there were some important qualities about the pattern of deterioration in Alzheimer's disease. So, and I personally was involved in not only putting the scale together, but also especially in carrying out a couple of important reliability and validity studies, both in the US and in Europe. As I mentioned in the presentation, it isn't enough just to create a scale, and to create a scale that looks like it's good. You have to actually demonstrate through statistical experimental techniques that the scale is valid and reliable, that it actually, as I said, that it actually does what it's supposed to do,
right,
and that it's a reliable scale, that if I do it and you do it, that we get more or less the same results. So, and it isn't just enough, as even Professor Spiro said, to do it in one language. Frequently it has to be translated, obviously.
Yeah.
So she was, for example, instrumental in translating it from English into Romanian. And that is, and she's absolutely correct, that's a very, very difficult process, because you have to go back and forth at least 3, 4, 5 times to make sure that the languages are equivalent in terms of covering the phenomena that have to be looked at. So the FAST was one. And then, as I mentioned, the second one that I was involved with, which is also part of our NYU clinical rating scale system, is the BEHAVE-AD, the behavioral disturbances in Alzheimer's disease. Otherwise, we call it the BEHAVE-AD. And that came about, also for me, because of my interest in aberrant behavior from my old days at Vanderbilt in schizophrenia and severe depression, but also because of something that happened when we were carrying out our various clinical studies to a patient, and we realized that this whole area, we were getting complaints. I should say at this point, we also had a couple of social workers who were working in the clinic who were coming to us and telling us that a lot of the spouses of these patients were telling us that they were having a terrible time dealing with some of the behaviors of the patients, which, we were not as familiar with at that point, because we had been functioning not only on the cognition, but on the functional changes. And a lot of these behaviors, of course, manifest because of the changing nature of the brains of the patients. A lot of these behaviors manifest in the late afternoon and through the evening hours. So we were not aware of a lot of this. Even when the patients would come into the clinic, they might sit in a very passive, withdrawn way. And, and then somebody would say, well, Mr. Smith can be a terror. His wife tells us he is a terror in the apartment. And we're like, this guy? Really? So, we were initially unaware of that. And so we had to devote some time to developing, as I mentioned, items that would cover some of the disturbances. We worked closely with John Overall, for example, who started the behavior, did the BPRS, a couple of other people, and we figured out ways of looking for behavioral psychiatric disturbances. And again, we had to do the item analysis, and I did a lot of the reliability and validity studies that were associated with that. So for me, it was mostly a little bit of the GDS, mostly the functional assessment staging, that's the FAST, and the BEHAVE-AD.
All right, so basically with these scales you have the more complex integrative approach on the pathology itself. And I was thinking that you mentioned before that you missed this part, that these types of diseases really make a negative impact on their relatives, their family, right? And I was thinking that you as a researcher, do you think that intuition plays a really important part in your field?
Yes, absolutely. In fact, sometimes I think it's the most important. And however, with that qualification, it doesn't mean that we operate with it all the time. As I said, we have our own, we meaning not just you and me, but even the group that I was working with. I mean, it's a good question, and I really think it's important even for me now, because I'm still continuing with the research. We come to a problem with our own biases. And, we have our professional self-concepts. We need to look a certain way or think we look a certain way, not only to our patients and their families, but to our other professional colleagues.
Right.
Okay? So when we think about problems and solutions to problems, there's a certain, scientific medical way that we like to think about it. And often the notion of intuition or, that itch at the back of the head or, in my case, somebody has to hit me over the head with a 2x4 before I kind of get it. You kind of ignore it. But the answer to your question is absolutely yes. I think there's the book knowledge that we all have, and then there's our creativity and just stuff that we sort of wonder through natural skepticism whether or not whatever we're being told or whatever it is we're hearing makes sense. And that is something that needs to be listened to. And I think because of this issue of the self-concept and how we want to appear to our colleagues, I think sometimes we tend to not forget about it, but I think we put it behind us and we don't pay much attention to it.
All right.
And I think, frankly, if I may jump ahead now, just for a minute, coming back to this issue of the intervention for Alzheimer's disease, I think to some extent that's partly what's going on here with the focus, as I mentioned in the talk, and we all know this, on senile plaques and beta amyloid, despite the fact that, since the 1970s, certainly really since 1968, everybody's been focusing on this, and nothing's happened. Now, other people would say, oh, how can you say that, Sclan? There's this, there's this, there's this. But in terms of actual practical results and meaningful results for patients and their families, not much has happened. And, at some point, you got to scratch your head and say, what are these guys doing? There's another way of thinking about this. So that's kind of where the intuition piece of it comes in.
All right. Yeah. I understand. And you mentioned creativity, which I think is one of the most important assets that we have. That even Einstein emphasized that creativity is even more important than knowledge. And being in this medical field for quite a long time, what do you think about our educational system, medical and non-medical education, regarding creativity?
It's interesting you ask. My wife is an artist.
Okay.
You didn't know that. I don't think I mentioned that. My wife is an artist. And she's had an enormous influence on me, particularly in terms of my clinical work. When I don't do psychotherapy anymore, but I had up until a few years ago because of the psychoanalytic training. And she's had an enormous impact on me in that regard. I would say that there's I think unfortunately and sadly, as we discussed earlier, the whole issue of creativity and intuition is something that in our professions is completely stepped on and basically, at least while we're in school anyway, more or less told to forget about.
And why do you think that happens? And that happened?
I think that, nothing is all good, nothing is all bad. I mean, I think clearly, Andre, we need, there's a basic foundation that of education that we need. I mean, there's a certain amount of facts, and I don't mean necessarily memorization of facts, but a certain basic understanding of how things work, operate, principles that we need to be aware of. And then one can go on and use that information in a more creative way to solve problems. I think that, as we were talking earlier, I think that it's been washed out of the system because so much of the system is based now on an economic way of thinking that demands that people do things in a more uniform way, and a misunderstanding of what outcomes of outcomes, and what may constitute a positive or a negative outcome. So let me, if I can, let me be more specific, because that I just, as I'm saying it, not satisfied with that. So based on my experience now, clinically, my clinical work, forget the research for a minute, clinical work, the clinical intervention in terms of be it psychopharmacology or psychotherapy in the US now is not being driven by individual doctors with their patients. It's being driven by insurance companies which say that they will pay the doctor or the patient a certain amount of money for a certain kind of intervention that they say is based on best practices. What is the word? Oh God, I'm blocking it. I can't think of it. But in any case, best medical practice. They meaning the insurance companies, to ensure that the outcome is, quote, good, that it's a good outcome. Now, what that's done, is created in a sense, a uniformity of thought regarding the nature of specific interventions for certain kinds of disorders.
Yeah.
Okay? So a patient comes with, let's say, post-traumatic stress disorder. I'm moving away now from Alzheimer's for a minute. Post-traumatic stress disorder. And there's a way of thinking about the etiology of PTSD, and therefore a way of thinking about the interventions that is now uniform, and the insurance companies now dictate what the reimbursement rates will be to the patient and, most importantly, to the doctor. And I say most importantly because if the doctors don't do what the insurance companies say they need to do for treatment of the patient, then we don't get paid.
Right.
So basically, the importance of the relationship between me as the doctor, you as the patient, and my responsibility to you is no longer between us. There's a third party that intervenes. Right. And I actually think that that's had more to do with this notion of killing creativity than anything else in medicine.
Yeah.
Because now people are saying there are standardized treatments for various disorders.
Yeah, right.
And we don't need you to think you're basically no more than just a worker on an assembly line. We will tell you what button to push or what cog to affect.
Yeah.
And your thought process about what's going on with your individual patient is no longer relevant. Right. We know better than you, even though we are not even physicians or doctors.
Yeah, and
keep that in mind.
Yeah.
Their priority is the issue of payments.
Yeah.
And what I've been shocked about, and I use that capital letters underlined and italicized in red. What I've been shocked about is that I see that the younger generation of my colleagues, physicians, clinicians, psychologists, are fine with that. Okay, I don't even know if they know that there's an alternative way of thinking anymore. I get paid to do this. I implement this intervention for this disorder, and that's the end of it. And there is no creative thinking,
Right.
even on the individual level. So if there's no creative thinking that's required in your training, because really what you have to do is just follow a cookbook of interventions, you're certainly not going to get it when you start dealing with research, because you don't even learn about research until much later in your career.
Right, and although I'm still in university right now, we've done some clerkships, let's say, in hospitals on different specialties, and they all have that guidelines, that are more or less compulsory, and people are following them, and basically, as you said, you just have to follow them. Your clinical sense and
Absolutely.
intuition and creativity are put aside.
Yeah.
And the problem is that the patients and lawyers are becoming more and more aware of that.
Yep.
And they are trying to rely more on some guidelines that even the term guideline is something to guide you, not to define a diagnosis. You can use them in order to help your diagnosis, to put patients in some categories, but they are referring to that, and there are so many processes and lawsuits regarding that, and I really think that that's the killing of the creativity and the clinical sense.
Yeah, the term that I was looking for a minute ago
Right.
is evidence-based medicine.
Okay.
Okay?
Right.
Now, somebody said something to me the other day, and it's absolutely true. Evidence-based medicine is just another word for politically based or economically based medicine. It's not really evidence-based medicine. And I can tell you that that's true. Because when you start looking at what evidence-based medicine is, they're meta-analyses of studies. And you know what meta-analyses are. It's just taking an area of question and, you're lumping the trials together. There are so many different variables that may not necessarily match. And I don't know, and there's a million ways. Again, this comes now back to my research. I'm sure you've heard of this. There are a million ways that you can manipulate statistics so that you get what you want. I learned that from my consulting with drug companies. So, evidence-based medicine, from my point of view, doesn't mean anything. But that's what it does. If I say to you, if I'm some lawyer and I say, blah, 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 evidence-based medicine, as the doctor, you think, oh my God, the last thing you want is, I'm going to get sued.
Yeah.
And you turn around and you just don't, you just kill the creative aspect of it.
Yeah.
And if something happens to the patient, this is the worst part.
Yeah.
If something happens to the patient, if you as the doctor have followed the guidelines or the precepts of evidence-based medicine, then you're okay, even if the patient dies. You did what was required.
Yeah.
And people turn around and they walk away. And that's killing the creativity. And as I said, if you kill it at the individual level, in other words, you as the medical student go in at your level and you see people doing that, then, you can see that as you get older and you want to go into, let's say, clinical research, it's played out at a different level. And basically what's being said is, guess what? Your career is not going anywhere unless you do it our way.
Yeah.
And creativity is just completely washed out.
Yeah, and that's terrible.
It was my wife who first noticed this. This is why I want to come back to my wife. Because she plays an enormous role in my career. It was my wife who first noticed that when we were doing our research, not so much at NYU, at the very end of NYU, but especially because of the work I was doing at NYU over a period of years. As I mentioned just a minute ago, I was doing a great deal of research for the international pharmaceutical companies on drug trials. And there was a small group of people who I got to know, and we formed a small private company because we were frustrated about how the process was going. And and whenever we had these meetings and whenever we offered a proposal, we were always shot down. We were always rejected. And it was my wife who began to realize that people were not interested in creativity, that rather there was an emphasis on uniformity because people's careers were based on that, certain ways of thinking.
Right.
And this was how things were supposed to be, and so consequently alternative ways of thinking about problems and solutions were just rejected. And she was the first one who started to tell me about this, frankly. I have to give her credit. It was not me. It was, I kept thinking I did something wrong, or we did something wrong in terms of setting up the proposal, or in terms of presenting the proposal. And it was my wife who first, as the artist, who first said, no, you got to see this for what it really is.
Yeah.
So the creativity piece of it is really being squeezed out.
And you know what terrifies me basically is that we are living in an era where everyone can speak their mind, can be heard, and this thing of washing out creativity, intuition, and things that basically makes us stand out from the others is trying to be washed out globally and on everything, not only medicine.
That's right.
And this is quite a problem.
Yeah, as we were talking earlier, and I really do believe that at the bottom it's an economic issue. I really believe that. Because, in one form or another, I mean, it doesn't have to be a direct economic issue, but as I mentioned a minute ago, when she first started to venture into this and explain this to me, she used to tell me that people's careers were, based on looking at beta amyloid and senile plaques. They built their careers on it. They're not going to put their jobs at risk. I said, no, they're doctors. No. I mean, let's just say we had pretty, avid discussions about it. But over a period of time, I began to realize that she was right. That's exactly what's going on. And it isn't just in medicine. I'm completely in agreement with you. You'll see it across the board in various disciplines, that there seems to be this emphasis on uniformity of thought. In reality, there's an emphasis on uniformity of thought. There's lip service given to the variety of thought and to expressing yourself, but that doesn't go anywhere. What really at the bottom is at the bottom, what's really moving forward is the impetus on uniformity of thought, because that's what people are getting paid to do.
All right, and as we talked before, that this creativity in some points leads to some very interesting and new ideas, and this thing, I don't think that creativity plays a very important role on the short run,
Right.
And people nowadays are just focusing on the short run.
That's right.
Just for their, as we talked, just for that immediate feedback. So they get approval. They know they are moving in the right direction, or in the direction that they desire. And I really think that one of the things that is killing creativity is that is our will for that immediate feedback in everything we do. Well, I really hope that you enjoyed the first half of the interview. Stay tuned for the second part that is to be released next week.